Can you hear me, please?
Yes, we can hear you,
Hi,
Mahipal.
morning, Milind. Visco dal दो. I'm doing this patient. She is a pleasant lady of 58 years of age, has a grade 3 cataract. ये 60, इसको 65 करो. 65, 65. Okay. Yeah. Okay. So look straight. Ask her to look into the light.
Light ನೋಡಿ ಮಾ.
Yeah, so this patient has been pre-cut on the maximum light बढ़ा देना. Just increase the light intensity, please. Microscope person, please increase the intensity of the light. Light, light बढ़ा दो.
Increase sir.
Yeah, yeah.
Increase ಮಾಡಿ light.
Okay, so this has been pre-chopped with a lens here. No, no, you are decreasing it. More. Okay, can you see these three lights, please?
Light ಕಾಣಿಸ್ತಾ ಇದೆಯಮ್ಮ? Light
Okay.
ನೋಡ್ತಾ ಇದೆ.
Side port. Okay, I'll start this procedure now. So basically, we ask her to look down.
ಸ್ವಲ್ಪ ಕೆಳಗಡೆ ನೋಡಿ.
Look down.
ಕೆಳಗಡೆ ಹಂಗೆ
Yeah.
ಅಷ್ಟೇ ಸರ್. ಅಷ್ಟೇ ಹಂಗೆ ರೀ.
Can we try and focus
Phenogen.
it better, if possible?
I just put this Phenogen, right? So we have the Indian Phenogen, which is phenylephrine plus you have the xylocaine and Visco. Thoda niche, look down, please. She's got a deep set eye, so I'll have this small little issue which I will with the deep set eye. Now, give me the knife. Milind, is the view everything clear, centered?
It needs to be slightly better focused, if possible. That's
Okay.
better. That's good.
Give me the entry port. Using a 2.8 knife, so I normally don't make my incisions with the Femto. So just going in and give me viscoat. Just putting some viscoat to protect the endothelium. Needle 26 gauge. So basically in the Femto we have made 4 quadrants plus we have done the softening which is 1000 micron cubes. I just go with a needle. You can see the capsular rhexis is free floating. You can see there rhexis forceps. I just can have this removed with the capsular rhexis forceps as you can see. So that's the full rhexis that has come out. Hydrodissection now, actually you have a good amount of pneumodissection that is done in a Femto. But you may or may not, but I prefer to do lift the capsule and the routine. You can see it's pretty well rotating. So they had kept a default of about 500. Give me some viscoelastic again. Give me the Phaco probes. No, ye nahi. Canla ke saath. So the settings, I don't know whether you can see, there isn't an overlay, but can you excuse me? Camera, ये इसको settings दिखाओ जरा. Milind, are you able to see the settings now?
Yes, we can see the settings.
Okay, so the settings basically 42, 37 occluded, unoccluded with 500 of vacuum and white star. So this is 60 as regards the energy. We'll be using pass low. Get the machine nearer. Okay, so this is a bent 20 gauge Kelman needle and I use a sharp chopper. You can see this is a chopper which is cutting as also it has a sharp tip. नहीं यार, give me chop. Why cortex? Chop. Oh, okay. No, give me chop. Okay. So you can see that's a pre-chopped nucleus. We can easily separate it. Again, you can see this is pre-chopped. Give me the quadrant now. We're shifting the to quadrant. Look into the light, please. Ask her to look into the light.
ಲೈಟ್ ನೋಡಿಮ್ಮ ಲೈಟ್ ನೋಡಿ
Okay, so one piece is gone. You can see these are the small fragments again. The beauty of the machine is that you can have the occluded, unoccluded, and there is a good surge control that you have.
Mahipal, do you have any particular preference for the pattern in which the lens is cut by the laser?
Sorry. Pattern, yes. So basically, if it's a very hard cataract, I don't go below 1,000 cubes. So that's what, because much smaller cubes become very difficult. If it's a very soft cataract or if it's a very hard cataract, in both those situations, I don't do cubes. I then, instead of 4, I'll go on to 6 or 8. For a softish cataract, I will not do 8, but for a hard cataract, I will do up to 8. Okay, and then I normally use a catalyst, so the repetition is 3 times that you have. That means for the cutting of the nucleus, the energy is more in the posterior, it is less in the anterior, and epi, and I do what uh, Dr. Chi has described, and that is that I do. Give me a manipulator. Yeah, मेरा एक rod होगा. That is that I do a central sparing. That means only the central 0.3, 0.4 rather a 1 millimeter in the center. I don't. Yeah, नहीं, एक blue rod होगा. So that is spared, so you don't really need that. So that saves a lot of energy according to her. So I do that settings, that's what I have. Okay?
Yeah, yeah.
Is very stable, the anterior chamber. It's peristaltic.
Sorry?
The anterior chamber is very stable. And it's peristaltic.
Yeah, chamber, it is a peristaltic that I am using. Give me viscoelastic and an IA. I am obviously I started Phaco way back in 1991. So at that time there weren't bimanual IAs. So somehow I am used to coaxials only. And I use a bent coaxial. And typically I will start from the subincisional, because that's where you have the most difficulty. So as you have the cleavage plane that's established, keep going along with that and keep pulling it out.
Mahipal, do you prefer this particular type of IA, or do you like, have you tried silicon tip?
No, they are not been marketed in India to any large extent, and I don't have access to it. I could possibly use it, but somehow I've never used them. I don't know why the companies haven't marketed Viscodena. I'm really not sure as to why they have not marketed, maybe the cost or whatever, but yes, that is majority of the people from West tend to use that IA. You prefer that, Milan?
Yes, I mean, that's a standard kind of a thing that we tend to use.
So do they cost significantly or what?
Well, they're all single use, so, I mean, in the UK, almost everything we do is single use.
No, but how much does it cost for the single use?
The hospital tells me it doesn't cost them much more than having to sterilize all the instruments.
Okay.
But of course, they tend to break half the instruments when they go into sterilization.
Okay.
But the UK sterilization process is very different because you need about, because of mad cow
Okay,
disease.
so I will, this is a small tag. I have not seen it in Catalyst, but you can see this small tag. Can you see that? But anyway, I'll just do a polishing of the posterior capsule. Okay, give me viscoelastic. I'm going to, this lady, the lens power that we are using is 24.5. That's Synergy. The Synergy is not a, have you loaded? This is not a blue blocker. This has got about 15 rings. You can see there's a slight yellowish tinge. So it is violet filtering. That's what it is. You get 2.8. Okay. So this is through 2.8, I think, the cartridge that they have given me. I normally prefer the roller type. That's the screw ball. I don't like the injector. And give me this Insky. And you can see that central 1.1, I'll just take away the air bubble. It goes pretty well. This is the Technis platform, except that it is slightly uh, yellowish. And 15 rings. It's a combination of an EDOF with a near ad. And 33 centimeters to infinity is what they claim. And you can see these rings. I'll just remove the viscoelastic, and that's about the end of the surgery. You can ask me, I'll just hydrate the wound. You can ask me any question, Milind or anybody has any question.
You don't, do you have access to the preloaded Technis platform here?
Sorry?
Do you have access to the preloaded Technis?
Yeah, we have. That normally we have the preloaded in the eye hands and basically in the toric variety. They are spherical. We don't have access to the Technis preloaded, but we have in the toric variety, whether it is the Technis or the eye hands toric, we have access to that. Okay, any questions?
What is your specific indication for using a Synergy rather than any other multifocals that you use?
So basically, I am not using any EDOFs. That's a lens which I feel is neither here nor there because it doesn't give you near vision. My total practice on monofocals has switched to the eye hands, and that is what I use, or I use another what they call as the extended monofocal lens, right? And then if a person really wants a near vision, etc., then I have this or another company's lens which I use, which primarily I say are these trifocal lenses exactly. So that is what the indication is, that if a person is a heavy reader, the dysphotopsias are much less. You put Vigamox, give me, on the top or intracameral? Where? In BSS, okay. Yeah, so that's fine. I think the surgery is completed. I'll just, so that's my indication as regards, ठीक हो गया. That's my indication. My monofocal practice has totally been converted into an extended depth of focus or whatever the advanced monofocal or whatever you want to call that. And the trifocals are the other stay. I don't use any bifocals. I don't use any lenses which are of the EDOF variety. I used a lot of Symphony, but the patient didn't get the reading ability. So you are asking the patient to pay more. Even other companies which have come out with the EDOF, the dysphotopsia is still pretty much the same. It's only in the advanced monofocal lenses that the dysphotopsia is not there. Yeah? Yeah.
Sir, just being a beginner for Femto Cataract, sir.
Yeah.
Just two guidelines, sir, regarding why, what's the reason for not taking main incision with Femto?
See, basically, I'm using the liquid optic interface. In the problem of a liquid optic interface, that's the catalyst system that I use. The applanation is not hard or it's not tough onto the cornea. So the microseconding movements or the movement that we have, the plane of entry is not very, you have to kind of struggle on the plane of entry. And you are really not achieving too much with the main incision or with the side port incision. So it's only when you have a hard dock in one or two of the machines that you do, and it takes more time to kind of open it and do that. The best indication, I would say, the three indications. The fourth incision, I keep it separately, but LRIs I do for cylinders up to 1 diopter. I normally go for a toric. My tolerance limit for a toric is 1 diopter. Below that, I use a toric, an LRI. And if this is a with the rule astigmatism, I am more tolerant on leaving behind a with the rule astigmatism. The second is obviously the capsulotomy, which is great specifically in the hypermature cataracts or the intumescent cataracts. And the third is to do a nucleotomy. Nucleotomy, specifically hard cataracts, reduces the energy, as also posterior polar cataracts. The OCT will give you an image so that you can leave a higher default. But majority of the femto surgeons are really not doing the main incision because it's a little more bothersome to open it, and it takes more time, and you are not gaining anything significant from the main incision as you can do with a blade also.
Sir, and
Okay?
thank you, sir. And second thing, sir, is there any difference between femto, like IA in femto and in IA in regular
Yeah, so
capsulotomy?
you see what happens is that there is a cleavage of the anterior capsule, anterior cortex that happens. So you have to actually go below the capsular ring. So you saw that at the superior incision that you actually, I had to go behind the capsular axis. That's about it. There's no other specific difference, but except that the fibers of the cortex gets cleaved because of the femto, because the femto is going deeper. Okay?
Thank you, sir. Thank you.
Okay, thank you. Thank you, Dr. Shri Ganesh and Supriya and the entire team of Nethradhama for giving me this opportunity to show the live surgery. Thank you. And thanks to JNGA for the machine. Thank you.